Okay, so hi everyone. Thanks for joining for our afternoon breakout sessions. We're very excited to have Dr. Singhal here with us. So just to begin, I'd like to introduce Dr. Singhal. Let me just pull that up. Give me one second. I'm sorry, my computer hasn't been working all day today. So, Dr. Rajiv Singhal is a urologist and an associate professor with the Department of Surgery at the University of Toronto. Dr. Singhal received his medical degree in 1990 from the University of Toronto and completed his postgraduate surgical training in the same institute in 1995. He joined the surgical staff at Michael Garron Hospital in 1996, where he currently serves as the surgeon in chief and the co medical director of surgery services. He was the head of the Division of Urology from July 2001 until October 2012 and founded the Surgical Robotics Program, jointly run by MGH and Sunnybrook Health Science Center in 2012, which he continues to lead. Since 2016, Dr. Singhal has worked overseas in Malawi, Kenya, Uganda, Jamaica, and China to explore opportunities to build urologic and surgical capacity in the developing world. He is the urology lead for the Global Surgery Initiative at the University of Toronto. Efforts to date have included training clinical officers to perform general urological procedures such as TUR surgery, as well as implementing surgical safety initiatives in Zomba Central Hospital in Malawi. Through COSECSA, which is the College of Surgeons of East, Central, and Southern Africa, mentorship and funding have been provided to train Malawian surgeons to gain certification in urology with a plan to return to Zomba. Welcome, Dr. Singhal. We are looking forward to hearing from you.
Wonderful. Thanks for that. I think when you have a long introduction like that, it just means you've been around a long time. So I do thank you for that. Thanks for including me, to Grace and Al Bors in particular for reaching out to me a couple of months ago and asking if I could be part of this. And I think I thought what I would just do is just break things down a little bit. I mean, obviously, everybody here is very interested in looking outwards into the world, and so I thought I might just reflect a little bit on my experience and sort of how I see from based on what I've learned in global surgery, and ideally just sort of leave it open to some questions afterwards. I suspect some of it, having just sort of set in on a little bit on the last workshop, might overlap, and maybe that's a good thing, right? I think just to maybe pick up and have some of those questions addressed through a different lens. So thank you for that, guys. I think the first thing I would say, I mean, obviously everybody here is engaged. I graduated in 1990 from medical school, so the entire generation that was really born after that I think in many ways holds the key to some of our great challenges around the world. I think as a generation, you're much more outwardly focused and globally minded and have a more fair view of the world. And in that, I think there's a lot of hope. So I appreciate that. And so, as we look at things from a physician and a surgical perspective, I think it is important before you go somewhere just to take a step back, right? And understand and maybe ask yourself a few things. And I think it's always important to reflect on your own motivation and the skills that you have. We all want to do well and do right by the world, and so I think it is important to understand what that means. What do you want to improve? Is it to make ourselves feel better? Is it to try and address a specific problem? So I think just taking a step back before you embark on an experience and just do a little bit of self-reflection, I think is really, really important. And then as you then go and target something, understanding the context of the healthcare system that you are going to work in becomes important. So take a step back and understand what that looks like. You know, what is the lay of the land over there? What is the population base? What are the challenges? Because the global health challenges are enormous, and anything we do individually without some thought is going to not really move the needle very much. I think it is important to understand those geopolitical factors that influence the environment that you're going to hope to work in. You know, I think a lot of what creates the structural inequity around the world is rooted in the nature of human behavior, right? And I think making sure and understanding, you know, can you actually impact on anything is important. And the other thing, of course, even on that front, just for your own personal safety, just trying to understand, you know, am I actually going to be able to go to an environment where I feel safe? And so I think that that's good, and again, it's something you need to do. And then, you know, I think you want to advocate. I think physicians forget about global health or global surgery. I think the nature of being physicians and being healthcare advocates is there is an importance in being politically engaged. You know, there's a lot of comment about staying in our lane, whether it's related to gun control and then some of the other challenges of our time. I think healthcare workers and physicians in particular have an important role to actually engage politically. So I personally think you shouldn't shy away from that, and then look for mentors along the way. So if we look at trends in global health, you know, I think a lot of what we want to look at in surgery really arises from the fact that we've made some progress. If you look back over the last 30 years in particular, there have been, you know, we've made significant progress in communicable diseases in particular. And so as that evolves, and as you can see, and if you look at sub-Saharan Africa in particular, life expectancy is going to increase. And so it makes sense that as people age, the problems that are going to develop are the stuff that we see in the West, right? And it's going to be cancer, it's going to be degenerative disease, and in that context, surgery in particular plays an important role, and I think it therefore matters. And so I think in that context, and I suspect most people here are familiar with this, but I think if you're not, I think, you know, this was a seminal paper on current concepts in global surgery, and the magnitude of the problem, and hope, you know, and how to address the problem. And so it would be worthwhile, and I'm happy to provide a link to somebody who, if you want, or even email you the full paper. So do let me know, but I suspect you all have access to it. But it was from 2015, and it's worth a review to understand what the problem is. And it's enormous. I mean, if you look at it, is only certain parts of the world, what we would call the developed world in the West, that have ready access to surgical solutions to health. And you could probably perfectly superimpose those colors around our current COVID crisis, I suspect. I think that would be almost the same in terms of the magnitude and around vaccinations and who's actually struggled and suffered. And so to put things in perspective, and again, I think, you know, you're a fairly sophisticated audience here. I suspect most of you know that if you look at fatalities, that again, if you look at it through that lens, that investing and addressing surgical solutions really matters, right? If you combine the number of people who die from HIV and tuberculosis and malaria at the beginning of the last decade, those who actually died from lack of access to you know, basic surgical care greatly increased or greatly dwarfed that. And so again, surgery matters. And I think in that context, it's very important to be mindful of that. And so those were the key messages from the Lancet Commission. Over 5 billion people lack access to safe and affordable surgical care. And as you can see, there is an unequal distribution. So of all the procedures taken worldwide, it's only an even smaller fraction that actually is performed in the developing world, and that investing in surgery is both affordable and it actually makes economic sense. And many people struggle and face great ruin financially by not having access to surgery. And so again, that's just sort of the review of the Lancet and the role of that. And this is sort of another way of looking at it, right? So even just from a, if you are, to look at the example of orthopedic surgery, if you had if you had a fracture that was never reset, and you're a 25-year-old, otherwise able-bodied man who is now chronically disabled, the impact on economically on that over the course of one's life is absolutely enormous. So by any of these measures, surgery in the developing world trying to figure out a way to address what we can do and look to move that needle matters. So how do you begin, right? And it's, as I said, it's particularly a problem in the lowest resource part of the world, which of course is where I have spent most of my time. So going to a specific place and just showing up and doing some cases and hoping someone's going to pick up on that is not really going to move the needle very much. I mean, I'm. Should we maybe, Boris? Should we maybe have a little back and forth, or should I kind of go through and talk, or do you want me to maybe just leave it open for a couple of questions even now, or should we move? What do you think?
For sure, it's up to you, and it's up to the participants if they have any questions that they would like to be discussed.
Anybody have a couple of anything want to address sort of around the broad concepts of the magnitude of the challenges of surgery? Or I can carry on if that's the case. But feel free to just chime in.
I had a quick question.
Sure.
Are autoclaves still hard to access in low income, low resource areas?
Yes. Yeah, no, for sure, right? And what you can do and clean, like say linen in and surgical and drapes is I have a little picture that I'm going to show you on how we sterilized some of our TUR instruments the very first time I went to Malawi, and I think so it is a challenge, right? And I think understanding those local challenges as you go and embark, and then reflecting on that after your first experience becomes a particularly important thing, because you're used to doing things a certain way here, and you got to just back up a little bit. Osamui, I see you unmuted your phone. Did you have a question? You did actually a second ago.
No, I had a comment. I was actually looking forward to listening to your perspective, because I've always thought about global surgery, but when I think about where do you even start from? It's almost like, so it'll be interesting to see your perspective and hear about how you've been able to go about it. That's my, yeah.
Perfect. Yeah. So maybe I'll carry on then. And so, it's interesting, right? So I guess you could look at it a couple of ways, and then I'll kind of reflect on sort of my own journey to date. But when you go into an environment, and again, just wearing a surgeon's lens, it's instead of sort of saying I'm going to go up and learn how to, or show people how to do procedure X, I think it's there's a few different ways you could look at it, right? You can look at it through a life course approach, and that makes sense, right? So if you and actually, if you understand, so let's use men's health as an example, right? So I am a urologist, and so if you go and say, okay, I want to go and I want to just figure out a way to do procedures to allow people to void so they don't have to wear catheters all the time. I mean, that would be one way to look at it, but really, is that really part of the way you should look at it, right? I mean, and if you looked at it from a larger men's health perspective, there's a lot of advocacy, like all of the things that affect men from a healthcare perspective, go beyond, say, urological issues, of which there would be a surgical part to that. But, there's an opportunity to address hypertension, to address heart disease, and all of those other factors. And, my very first trip, I don't have it on this desk, my very first trip I took to Malawi, I was very, very naive, and I said, okay, let's go and do let's go and do a case. And and the patient showed up in the OR, and his blood pressure was 230 over 130, right? And when you realize, well, wait a minute, it doesn't really matter. Like if he's walking around with that kind of blood pressure, I think we better address that sort of thing first. And so I think understanding it through either a disease burden approach or a level of care approach. So and there's no right answer. I sort of put this slide up as a way just to sort of illustrate that surgery has a role in the structure of the healthcare environment that you're going to work in, and understanding that environment and seeing where you can fit, wearing your surgeon's hat is going to allow for some more success, or at least move the needle. So that's one way to look at it, right? And then of course, if you had to pick anything, and again, this comes straight from the language of the Lancet Commission. I mean, they talked about the bellwether procedures, right? And so it really is important. So if you could invest in nothing, and a good way to kind of, if you go to an environment and you're going to go and try and see how you can address surgical need, my work in Zomba Central Hospital, for example, is different than when I went to rural Kenya, which was a much more basic sort of environment. And so it makes no sense for me to even begin to address, well, let me see if I can manage the problem of chronic catheters and prostate disease if you don't have some basics in, right? And so if you could invest in, so I think when you go to an environment, and you want to understand what that environment looks like from a surgical perspective, it's very good to do a quick count and say, is there capacity to do these three basic things, right? The so-called bellwether procedures, because this is what people die from, right? More than anything else around the world, if they don't have access to surgery. Obstructed labor. So if you have nobody who can do a C-section, you're going to have a lot of maternal death. And same with laparotomy, to deal with bowel obstruction or appendicitis or any of those kinds of things. And then, of course, open fractures. And so as you think about that environment, do a quick little scan in the lay of the land. And this is a way of taking inventory, right? If I'm going to go there, are these things in place? And if they are, then looking back at that last slide, you can then start to look and look at it a little bit more deeply in terms of, okay, well, now let me see how else I can kind of look at it. But, these are the basic things you want to take inventory of, depending on where you're going to go. And then with that, of course, comes, to be able to provide safe surgical capacity, you need the ability to give this basic care. You need a system to get people to that hospital, and or that healthcare facility. And then, of course, the other part of surgery is you need to make some assessment of what that actual operating room looks like, or that operating environment. Is there anesthetic support? What kind of anesthetic support is there? So this is how you have to think about things. And so it goes back to that original point that I made at the beginning, which was give it some thought, reflect on your motivations, and understand the work environment you're going to go into. And so, it's interesting. This generation, of course, you guys are going to understand. And if I look at the mentor list after this workshop, those are very accomplished, scholarly, highly accomplished folks that are really going to move global health and global surgery to the next level. Many of us have come to things, relatively late. I mean, for me personally, a lot of it was, I've had a long career here in the city in surgery, and you get to a point where you understand some of the dynamics that affect access to healthcare, even here in Toronto. And at a personal level, I got to a point where my kids were a little bit older, and I was able to explore this need, and then come at it through a lens of an experienced surgeon. So, I've been on a number of trips. You can see it's not a long journey. It's only 5.5 years. The last year and a half has been unfortunately aborted because of our pandemic. But it is interesting because it has allowed me to understand different kinds of environments and what we could do. And so I just thought I might just spend a little bit of time just kind of going over a little bit of my basic early experience. So this is Malawi, and Malawi is primarily a rural country. There are 4 cities, as it were. Zomba, as you can see in the southeastern part at the bottom, is primarily where I go. That's the hospital where I've been at. That was the operating room that we first arrived at, which was a sort of neglected, unused space. It subsequently has been given a little bit of a paint job. But you go up the mountain to the plateau, and you realize that there's a lot of beauty in the world, and that really is a view almost just as you step out of the hospital. You can see that view in the bottom right-hand corner, and so it's a pretty special place, and it's become very near and dear to my heart. And so it's very, very poor, and as I said, most of it is rural. There's only a small proportion that lives in a city, and the nature of urological care. So when I went at the beginning, it was purely to understand it initially through the lens of me as a urologist. The nature of that required coming into some of the bigger environments, and so Zomba is the 4th biggest city in Malawi, but it's not very big. It's about 80,000 people, and there's a large area that drains around the region. That's all very much rural. And there are people literally walking around with chronic indwelling catheters for years with really no way to address the problem. So this is a fundamental men's health problem. And if you look at it from the, well, how do you fix it, right? So you have, many common things we see here that you would see there. We do know from a genetic point of view that Black men have a much higher risk of having prostate cancer. And in many ways, what I've seen in Africa and in Zambia in particular is what an unscreened population looks like in terms of advanced prostate cancer. And certainly, certainly that leads to a significant amount of morbidity and mortality. And so when I got to Malawi in 2016, so in Zambia, you can see the numbers in terms of who would service the communities. There were 0 urologists in the country of Malawi in 2016. And so I think you asked me, Abrar, around autoclaves, and we have Steris machines now to look at our to be able to sterilize our scope equipment here in the West. And so I naively thought I'm going to teach them how to do TUR surgery. And I suspect at least some of you know that a TURP, which is a transurethral prostate resection, is a common endoscopic way to try and deal with enlarged prostates. And so we had, we brought a couple of sets of these instruments over, and that basically is what you would do. You would take inventory, and when you were finished, you would throw them into this bucket and throw the precept and soak it basically for about an hour of time. And that was our sterilization, or at least that is what I came up across. So clearly not very ideal. And that blue bucket, so here in the West, when you're doing these cases, you run these irrigating fluid bags into your scope so you can see it all the time. We basically had a blue bucket that we filled and used gravity to be able to do these cases. So that's the lay of the land, right? So it was a little bit naive on my part to be able to come and show up. I had this little device, you can see this round portable light source that's a little bit of an early prototype of a light source that you can use to avoid towers. So it's great. We used it. I was actually able to project things off of a wall. But again, you can see that would rely on a lot of equipment and expensive equipment that would need to be maintained. This fellow on the screen is Duncan Goche. He is a clinical officer in surgery at Zomba Central Hospital who I've gotten to know well, and it's sort of taken a shine to understanding some of the urological problems. And so, it's interesting. So that was my very first trip on working overseas. And so I thought to myself, what is the bigger problem? Is it, if I just looked at things from a urological perspective, is it to teach people and to be able to bring TURP surgery to the developing world, which is minimally invasive and less painful and the like? Or is the problem from a health systems perspective and a health problem perspective, is it to actually get people to be rid of catheters? And so then you start to think, well, you really want to be able to work within the capacity of the tools that you have. And so when I went to Jamaica, to rural Jamaica in 2018, and that was the job, that was the hospital there. Like that's an enlarged prostate, and in my left hand is a big bladder stone as well. So we just did that through an incision, right? And that is something that you can potentially train a local general surgeon to do, somebody who's got some reasonably good laparotomy skills to be able to look. So that sort of framed how things would go. I think somebody in the earlier on had talked about Lee Arrett. You might notice that's Lee here in the bottom left-hand corner. Lee is my global surgery mentor. I spend a lot of time talking to him around, what do you think? So the Jamaica project, of which he's asked me to sort of be the urological lead on, is very much driven by him. And in fact, we were supposed to be back in Jamaica at that same hospital at the very last week of March 2020, which of course is when the world fundamentally changed. Asamu, you have your hand up. Do you have a question you want to ask?
Yes, I do have a question. That was looking at when you went to Malawi the first time. You said part of what you wanted to do was to assess what type of need, or I think that's to assess what challenges they were actually facing, so you know how to address it. What did that look like? I mean, like, were you talking to the doctors? Were you so what yeah.
So I might sort of have you hold that again, so I can
Okay.
I can maybe address it, but I mean, what I would say is it all starts with local, right? So you need to understand, and I caught the last few minutes of Dr. Cusimano's talk as well, right? I mean, I think what it really reflects is building relationships on the ground, whether there's a nearby university, at the local hospital. You want to understand, well, who's actually there, right? Most of sub-Saharan Africa, surgical care is delivered by clinical officers, right? And so you have to understand, okay, this is what's here. And it's not just a matter of teaching them to do a case. So if you look at it through a urological lens, I would submit that some of these men walking around with chronic indwelling catheters, they just get neglected. And part of the didactic teaching is actually taking a step back and teaching them a little bit about the natural history of BPH, which might be that, with some decompression, some of these people, if you just take the catheter out, may actually successfully void, right? But there's a lot of complex things. In the West, we have access to alpha blockers, Flomax, whatever the thing might look like. But so you need to understand what you have there. Anesthesia capacity, clinical officers versus surgical capacity. I have some slides near the end. You need to understand who the administrators are at that local site. Are they empowered? What's their motivation? Are they prone to corruption? I think these are all things I've come to learn, and then trying to understand things at a countrywide, like the higher you can get in terms of being able to get to the decision-making machinery, I think is an important piece. And so I'll start with that. And again, just not to belabor some of the journey, if you will, but when I went to rural Kenya, actually, I took a group of my colleagues with me from the hospital. So this was not at all a urology trip. And this is about 2-3 years later, but was very much about let's see if we can kind of mete out the bellwether aspect to a small rural hospital. And so this team includes, well, that's my son, the second from the left, but it includes anesthetists, it includes nurses in our OR, and another general surgeon who came with me. And so, again, trying to understand it through the framework of the Lancet Commission, and a great bonding opportunity as well. I mean, it has had a lasting impact here at Michael Garron, you know, in the 3 years since that time around, you know, those that went on that trip. So there was an intangible benefit that came from that. But, you know, local issues, again, you just asked me that, it's a lot of things. So I've always been, I always like putting this little slide up here. If you look at, so that's the consent form for surgery at Zomba Central Hospital. And I crossed out the names, obviously, but so that passed for surgical consent. And which, needless to say, left me a little bit uncomfortable. And so, you know, you realize I think maybe the thing what this highlights, if you're not careful and you're not thoughtful, the ability to do real harm is enormous, right? So like, I mean, I could pretty much do anything to this poor patient. And obviously, if I didn't understand what my own goals of care were, it was not going to be something particularly good. But I would argue that even just do the surgical safety checklist. So, you know, after that first trip to Zomba, it dawned on me that I could actually create a safe surgical environment just by obsessing and spending a lot of time even around this. You know, the very first time I went there, the administration had sent some low-level person in the hospital off to, you know, to do a little conference out of that city into another part of the country. And it was clear he just kind of went because it was a trip. Nobody debriefed him. Nobody asked him about it. And I said, well, tell me about the surgical safety checklist. When I came back, nobody knew anything. And then I literally turned around and I looked on the wall and somebody had just sort of taped it to the wall, right? But there was no internal way to sort of harness something simple as that, right? And so, you know, safety checklist, being able to do pre and post-operative sponge counts, these are all things I've come to realize you can spend a lot of time. And so, you know, I think as I left, particularly in Malawi, as I left, that, you know, the problem is enormous, and so you have to take inventory. You know, basic care, I think, can be provided a number of different ways. Ultimately, you need to see what's available. I think the clinical officers can be upskilled to do a number of things, and there may be some opportunities to actually build out the urology residency program even here in Toronto, and kind of build an elective rotation, because, and I'll get into that a little bit later, I think being able to work in other environments, I think, will make better surgeons here as well. And so I might just then spend the last little bit, because I really want to just kind of leave it open-ended then. So I think you, in my introduction, Abrar, you talked about the College of Surgeons of Eastern, Central, and Southern Africa. So, you know, as you look at what's on the ground, and my first naive experience when I went there, you realize that you have to think about what is the problem you're trying to resolve, or at least help improve, and then you need to figure out how are you going to leave expertise behind in order to be able to do it, right? And so we talked about clinical officer training, but there's no doubt that formal medical training of actual surgeons is important. And so the College of Surgeons of Eastern, Central, and Southern Africa, if you look at it from a UofT surgery perspective, has become a very important strategic partner and priority lever in order to be able to address where we might want to be able to move in terms of building surgical capacity in Africa. And so basically, think of it as Africa's Royal College. Now, not all of Africa, it's the eastern limb, if you will, but it includes, you know, 14 countries, including Malawi and Kenya, you know, a lot of whom really, if you look at things before independence, had an English influence, a British influence to their history. And so a lot of the standards and a lot of that influence around medical training can come from that. And the fundamental principle is if you can train bright young people locally, and it's going to cost, that you have a much bigger chance of being able to retain and keep people there. So for example, I've been blessed to live and grow up in Canada and raise a family in Canada, and it's influenced sort of my outward view of the world now. My father and mother, when they came in the 60s, my dad was a surgeon. He came for surgical training and he stayed here, right? And so I think you want to be able to move people and ideally keep them. And so the full gamut of surgical training is available in different parts through COSEXA. And this is a 2019 slide. I'd have to look and see what things are like now for 2020, but you can see there's been a rapid expansion in being able to train really the equivalent type of surgeon within these countries. And then, as I said, the most important thing, there's an annual graduation, obviously, but the most important thing, and you could see Malawi as an example. Again, it's a small country relative to Kenya, but we've trained 16 surgeons in that group, and retention is the big piece, right? So if you train an African surgeon within an acceptable African residency program, the odds of being able to keep that expertise within a sub-Saharan African country is much, much higher. And if you look at Malawi in particular, but really it's a pattern that you see emerge throughout, it holds true. So it is a key vehicle to addressing surgical capacity around the education piece as we move forward. And so, what have we done so far? So I'd like you to meet Dr. Wanengwa Chisenga. So, the one thing I did do after I first went to Malawi is I started a fund. I started a fund at the University of Toronto. You could look it up. It's a global urology fund, which has, for the most part, been philanthropically managed so far. And from that, we have funded training and tuition. So Wanengwa graduated in December 2019. And if you remember, I said there were no urologists in 2016 when I first came. He's now urologist number 2. There was one that was just finishing who was being funded through another group and who came back just at the same time as Wanengwa. So you can get a sense now, I have a local partner, somebody I've gotten to know, and he is now a urologist. So he is now finished and he returned to Zambia, unfortunately, just as the pandemic started, but is very much settling in. And so you asked me again about local partners. So the fellow on the right beside me there is Dr. Eric Borgstein. If you look him up and Google him, you'll see there's a great picture of him with Madonna. So Madonna, of course, adopted her 2 kids in Malawi and has been very influential and has funded a big pediatric cancer center, surgical center. He's a pediatric surgeon, but he is also on the executive at COSEXA. And right from the very first time I went to Malawi in 2016, I made it a point to meet him, talk to him, understand things in terms of what we would like to do. And so I run all of those ideas around who do we want to invest in training by Eric, a really important key piece person locally on the ground. And then these are the other partners, right? So in Zambia, the fellow in the middle, that is actually a COSEXA trained general surgeon. He is now the surgeon in chief, if you will, at that site. Delia to his left, to his right is an anesthetist. I have a call this afternoon with her and her colleague. We're going to actually put some tuition framework in place to actually start the fundraising on, to start funding the COSEXA equivalent for anesthesia. And then the other group is, see if there's other interested people from overseas. So this group on the right are my German colleagues, that have sort of funded the Zambia Urology Project. And so we've been able to grow and build and develop things. And so my primary focus has really been to understand things, so the patient care and the educational piece, really go hand in hand, but capacity building understands figuring out what the problem is on the ground, understanding that, and then really through those relationships, you can certainly train clinical officers to do certain things, and then the surgical capacity, and I think needs to come through I think through CASEXA. So that's sort of what I have come to learn as we build things out. And then and again, I know I probably run a little bit late on time, and I do want to have a couple of minutes more for questions. But so some of these other pieces are now coming into play. The bullet point 3. So we actually have had in the urology residency here in Toronto, we've actually had 2 of our residents go over as PGY4s. They spent a 1-month rotation elective there, working with clinical officers under the umbrella at the time of the general surgeon. And now that I have Wanengwa there, it's going to be a little bit easier. It's been deferred, of course, because of the pandemic. But I think there's a real opportunity for surgical trainees here. I mean, I think it serves a number of purposes. One, I think it allows them to understand how they may want to look at their own global surgery journey. But I think it's also healthy to go in an environment where you're used to having this suture or this thing in front of you and being able to think on your feet and understand, well, maybe I should not do this because I don't have access to this, or maybe this is the best pathway to no harm. And so I'd probably just leave it at that. Philanthropy, as I said, is a big part of it. My fund currently has about 1.5 million in place. Most of it is just sitting there ready to use. I'm planning to do it. We've started the funding for 2 more CASEXA trained urologists, so that'll be 5 years. As I said, we spoke about anesthesia. We'll have people go over on rotation, and we'll see how it evolves. But that's sort of and these are a couple of the trainees that have gone over. Tristan on the left actually became my fellow as well last year. He's a great young guy. He's now in BC, and he's going to be one of my lifelong partners in global surgery as we move forward. And so I might just leave it at that. It's also a lot of fun. So I put these pictures were 24 hours apart a couple of years ago. I left a brutal snowstorm in Toronto and found myself in a nice warm country 24 hours later. And it's lots of fun. It's very rewarding. It is a chance to make the world a little bit better and address some of the inequities that I think concern us all. So I don't know if maybe Abrar Alborz, if you want to maybe sort of field questions, and I'm just happy to take them.
Of course, I can do that. I just want to begin by saying thank you so much for your talk, Dr. Singhal. We all learned a lot. And so as Dr. Singhal mentioned, now is the time for questions. If anyone wants to mute yourselves and ask the question, feel free, or I have the chat open as well. If you'd like to type in the chat, I can make sure that Dr. Singhal gets the question.
There is a hand up, but I think we answered that already. Is that true? I think, yeah. Guys, does nobody has anything for me? Just
I think Ozair just unmuted himself.
Oh, hi there, Dr. Singal. Nice to meet you.
Good
and thanks for the wonderful presentation. My name is Ozair. I'm a second-year medical student here at UofT, and I actually work with Dr. Eric, so it's nice seeing his face on the slides there. My question to you is, why Malawi? Do you have any connections with Malawi, or why that place, or Eastern Africa in general?
So good point, right? So maybe I'll say, I wanted to. So a couple of reasons. One is and it addresses maybe that first point I made. So I did actually have the great good fortune of meeting James Orbinski, who is a global health icon here in Canada, who spent years at MSF. He founded an organization called Dignitas International, which has now dissolved, but was worked to kind of solve the problem, bringing antiretrovirals to Malawi. That's where James was at the time. And so I actually was asked to join that foundation. in 2013, 2012, somewhere around that. And I remember at the time, part of it was to start to learn, right? And I wanted to understand. So before I left in 2016, I needed to understand global health, at a more rooted level, at a more basic level. And so in part, that was why Malawi sort of happened, and the other piece that attracted me to Malawi, if I was going to try and impact some change, I did want to go to a place where it was politically stable and safe, at least as I kind of understood things. I would not necessarily have wanted to go to Mali, for example, right, or other parts of Africa. And it was English speaking, right? And so that was an important piece for me, so that I could at least not have those barriers to further impact my inability. So I think that's really where Malawi came from. India, where my background is India, I wouldn't rush to go to India anytime soon, because there's a lot of inequity in India, but there's a lot of internal ability to solve a lot of their own problems. And so that's a political challenge, right? You have 500 million people that have all sorts of access to everything, right? And so at a societal level, there is too much, there's an inequity in the distribution of resources that I think would need to be addressed first. So Malawi is uniformly poor. And
Dr. Singal, sorry to cut you off. I think we are just at the last seconds of our breakout.
Yeah,
Thank you.
it looks like we're gonna go. Yep.
Thank you again.